Denise Tiran. I am a midwifery lecturer specialising in complementary and alternative therapies. I have spent almost all of my professional career working in the field of complementary medicine, and was very fortunate to be given opportunities. When I worked at the University of Greenwich as a midwifery lecturer, I was given opportunities to develop some of the complementary therapy elements, even back into the, I think, early 1980s, a long time ago. And I was also able to develop a degree in complementary therapies at the University of Greenwich, which ran for about 15 years. During that time, I set up a clinic at one of the local hospitals in southeast London, and that was providing complementary therapies for women who had problems during their pregnancy. So it wasn't specifically for things like relaxation. It was more to do with the symptoms that they were experiencing: backache, carpal tunnel syndrome, constipation, anxiety and fear, and things like that. I've trained in quite a lot of different therapies, and so when I work, I am not working as a therapist. I'm working as a midwife, using therapies as extra tools. So they give me a whole new load of tools to add to the kit bag of things that we already have as midwives. And I've been involved in research. I've written quite a few books. There's a few over there for you to look at. So I've done quite a bit of research in complementary therapies, general and maternity. For example, I did a study on using reflex zone therapy, which is a type of reflexology, to predict stages of the menstrual cycle, obviously in non-pregnant women. I've also looked at continuing professional development amongst complementary practitioners. That was a Department of Health funded study. And I have investigated elements of pregnancy sickness and the type of therapies that women use. More recently, I was involved with one of the Kent maternity units in looking at acupressure for post-dates pregnancy. So I've done quite a bit of research, and that has sort of informed a lot of what I've done. But I do sometimes think that actually we are so focused on research, and sometimes complementary therapies don't fit in with the research. Because it's so individualised, it's really difficult to have two groups where one group gets the thing you're testing and the other group gets is the control group. So it is quite difficult with research in complementary therapies. And then about 15 years ago, I left the University of Greenwich and set up Expectancy, which provides courses for midwives. I am really absolutely adamant that midwives need good quality training. It needs to be accredited, but it also needs to be completely and utterly applied to midwifery. It would be no good going and training, for example, as an aromatherapist and learning how to treat men or elderly people or ill children, because that's not applicable. So all of our courses are directly focused on midwifery. And my personal philosophy is about safety, professional accountability and evidence-based practice where possible. So we've been working now with a range of different courses for midwives, and doulas come on some of them. And the team has grown, and I am beginning to step back. I do a lot of work overseas, actually, so I spend my time on planes quite a lot, eating up the carbon emissions or doing whatever you're doing when you're flying. But I do have a lot of work in the Far East. So let's have a little think about complementary therapies and what they actually are. The words complementary therapies are often spoken as if it's a single thing, but of course it's not. It's a range of up to about 300 different complementary therapies, alternative therapies. I think the important thing for us is that whilst in general healthcare, people often talk about complementary and alternative medicine. For midwives, it needs to be complementary to the midwifery care and the obstetric care that women are getting. So it's not really an alternative. Even if women choose, for example, to go and see an osteopath because they've got a bad back, we need to know about that. It's really important that we do know about what they're doing outside of mainstream maternity care. On the whole, the words complementary therapies refer to manual therapies, so that would be things like massage, aromatherapy, reflexology, shiatsu, which is a Japanese version of acupressure. It might include things like acupuncture and Chinese medicine, but it doesn't include herbal medicine and aromatherapy oils and homeopathic remedies and things. That is natural remedies. That's classified as natural remedies. And all complementary therapies and natural remedies are only regulated by the professions. They're not regulated by law, except for osteopathy and chiropractic. So osteopathy and chiropractic, which are manipulative therapies to realign your musculoskeletal system, are these therapies are now regulated by law since the middle 1990s, and they're not really considered to be complementary therapies. So we're looking at things that we can bring in, as I said, as our extra tools. The problem with the natural remedies is that these are the things women often self-administer. And you might have had women bringing their own oils into the maternity unit. They might have told you that they're taking raspberry leaf tea to prepare for labour, or they might want to use homeopathic remedies and things like that. Now, none of these are regulated by law, although herbal medicine and homeopathy are fairly well regulated within their own professions. But the problem is women think that they're safe, and they're safe in pregnancy, and they're safe for childbirth, but quite often they're not. So things like herbal remedies and essential oils used in aromatherapy, those work pharmacologically. They work in exactly the same way as medicines, irrespective of the way in which they get into the body. And they then break down, they're metabolized in the same way as drugs. Many of them are excreted via the liver, and herbal remedies in particular, a lot of them have the risk of liver toxicity, or they have the risk of causing thinning of the blood, so they shouldn't be taken by women on any type of anticoagulant therapy, including, you know, things like aspirin that they might be taking as a preventative. And this is the one that causes me most concern out there with the pregnant women, but I'm also concerned about midwives who are beginning to use complementary therapies and not necessarily realising that they are professions in their own right, and we need to respect that, and we need to consider that we're only taking a very small bit off the top of that profession and applying it to midwifery. Why do mums-to-be want to use complementary therapies? And you probably have all known people who have wanted to get involved in natural things. They do think natural equals safe. One of the biggest areas is so-called natural induction. It's not really natural at all, is it? Because your body's supposed to go into labour. But women are trying all sorts of things, castor oil and pineapple and clary sage oil and all these sort of things. And sometimes that is quite unsafe. Occasionally it can actually cause excessively strong contractions that will lead to fetal distress. And these are the sort of messages we as midwives need to be getting across to women. A lot of them want to use therapies such as massage and perhaps reflexology, and certainly oils for pain relief in labour. But by the time they've got the baby in their arms, usually the use of complementary therapies does diminish a bit, as you might expect. Although the other end of the spectrum, before pregnancy, there is quite a lot of use of complementary therapies where women are having fertility issues, or couples are having fertility issues. And Amanda does a lot of work with acupuncture and Chinese medicine with women and their partners who are struggling to get pregnant. One research study you might like to look at is Kennedy et al. And that it was a multi-country, multinational study across 23 countries where they looked at women's use of complementary therapies. It seems to be highest in places like Russia, moderately so in Europe and the USA, quite high in Australasia, but generally not so much in Africa. Of course, that might be where people are using remedies and plants that are growing in the local country, and there is a high percentage of the use of these plant remedies in the African countries and South America, in the developing world, for babies, and that is causing a problem. In South Africa, actually, there is a Zulu remedy for getting you into labour, which contains something like 51 different plant ingredients, which, of course, it's a bit of a secret recipe. The sangomas will not reveal what is in that, and that causes problems for the midwives, the conventionally trained midwives in South Africa, because they're having women come to them who are potentially getting complications that might be related to having taken this particular remedy to get themselves into labour. And I think, these are the similar sort of issues for us. Now, why would we want to use complementary therapies in our practice? I think it's fair to say we're all overworked, often burned out. We are still wanting to work with pregnant women, but actually a lot of midwives are fed up with the technology, as are the women, of course. So the one thing that using lovely relaxing therapies like massage and reflexology and things like hypnotherapy, what they do is they cause relaxation. There's a lot of research to show that these therapies will relax you. And of course, if you are relaxed, your stress hormone levels go down, and that automatically allows your birth hormone levels, your oxytocin, to come up. So at the very basic level, using a nice relaxation treatment can be very, very beneficial. And we were just talking earlier about somebody who's just had a baby and where acupressure was being used, and how you notice a difference between a woman having a labour that's facilitated by acupressure, which is thumb pressure on the acupuncture points, and it calms them down and it aids progress, and it just facilitates the whole natural process towards a physiological outcome, rather than having that potential cascade of intervention that you get by starting off with prostate pessaries or something like that. Using complementary therapies can sometimes help with continuity of care, although I'm not convinced that is necessarily what we achieve. It's what we might want, but it's not necessarily what we achieve. It does concern me that occasionally maternity units might have just one midwife trained in one therapy and another midwife trained in another therapy and another midwife trained in another therapy. And that doesn't really provide what I would like to see as an equitable service, providing a service for as many women as possible. So it's far better within an NHS unit for as many midwives as possible to be trained in the same therapy or the same techniques, so that you can audit them and you can advertise that as something that is offered in that unit, and you can demonstrate that it has some effectiveness, and particularly around things like getting women into labour who are simply overdue and they're not, they don't have any other problems. Or you might want to look at things like reducing your caesarean section rates. Okay, how can we keep women in the birth centre or at home and avoid transferring them through to labour ward for caesarean, or even for an epidural? It might bring the epidural rates down as well. Using complementary therapies certainly improves midwifery satisfaction. Of course it improves maternal satisfaction because they like it, but if the midwife is also re-engaging with her work, then that is going to make her feel better. There have been studies which have shown that bringing in therapies like aromatherapy increases midwifery recruitment and retention. So, and it's because midwives want to be providing those sort of services for women. Again, I've put a query against whether using complementary therapies reduces midwifery workload. In the long run, it will do, but initially, when you're learning and you're setting up, and you're developing your guidelines and things like that, of course, it takes a bit longer initially, but it will eventually become part of what you do, and it particularly works in labour, where you're already working on a one-to-one basis with women. This is a slightly less negative thing. Does the introduction of complementary therapies mean that it's giving power to midwives where perhaps they've lost some of that power? As long as I've been a midwife, which is a very, very long time, there's always been tension between midwives and other professional groups, and between midwives and women sometimes, because women have felt they're not getting what they wanted. And I just wonder whether our desire to bring complementary therapies into midwifery is necessarily always for the best reason. That's just something to think about. Of course, I wouldn't be here, many years into my career, still providing courses for midwives if I didn't think there was a value to it. And I would love it to be part of midwifery training. Not necessarily learning how to do the different therapies, but having an understanding of what's available and what implications there are for midwives and how it fits with the care that we're providing as well. So that's just a little reflective question. The benefits in midwifery are, as I said, reducing cortisol, stress hormone, and increasing oxytocin. There is sufficient evidence to show that therapies like massage and aromatherapy, acupuncture, and hypnotherapy actually do reduce cortisol levels. So that is a really good thing. But of course, if you then aid physiological birth, you're potentially reducing the need to interfere with other things like induction of labour or epidural, because women's pain relief is better and things like that. And sadly, looking at it from an NHS perspective, if you reduce intervention, you then hopefully reduce the risk of litigation, which we've just heard on the news recently. Maternity is the largest area for legal cases, and it costs the NHS billions to pay out for problems. If you enhance women's satisfaction and you aid physiological birth, you're far more likely to have a satisfied customer at the end of what you're doing. Said about the reduced workload, but it might also save money. If you can save one cesarean because you've aided physiological birth, you're saving about £1,500 a time. So if you can reduce a 30% section rate in a 6,000 birth a year unit to 25%, you're saving a hell of a lot of money. You're saving maybe $250,000 or more, because you are not having as many women going through cesarean and all the things that go with that, a longer inpatient stay, potentially a baby that's needing to go to special care baby unit, and ongoing long-term effects on the mother's body. So it's really valuable to bring complementary therapies in. Now, we won't spend a lot of time on the professional accountability issues, but of course you have to work within your NMC code. The Nursing and Midwifery Council basically says you can do what you like so long as you know what you're doing. And you have to have had adequate and appropriate education, including continuing professional development. And you've got to be able to justify what you're doing. So you could go through your NMC code and you could look at every single clause and try and relate it to the use of complementary therapies. Are you prioritising care? Are you ensuring, for example, that you're taking account of your own safety as well as that of others? And aromatherapy is a case in point there, because if you're using aromatherapy, you need to consider it in terms as if it was a drug, actually, and you'd only provide aromatherapy for that woman. We certainly don't want billowing clouds of aromatherapy vapour going down the corridor because that is then going to affect absolutely everybody who's exposed to that nice smell, but the chemicals as well. So we would not want women in preterm labour, for example, to be exposed to the chemicals in the oils that we use to encourage contractions. We wouldn't want women with low blood pressure to be exposed to oils such as lavender, which reduces the blood pressure. And aromatherapy is a real issue for us as midwives, because it is so popular both with the women and with the midwives. But we do have to be sure that we are protecting everybody, including the midwives. For example, if you've got a pregnant midwife, should she be using oils to encourage contractions in a woman who's labouring at term? You know, it's not necessarily what you would want, and she needs to be aware of that. If you have had adequate and appropriate insurance and you've got permission within the NHS to use the complementary therapies, you've gone through the process of implementing it and you've got up-to-date clinical guidelines, then your NHS vicarious liability insurance will protect you. So you don't need extra indemnity insurance. Even if you're not a qualified therapist, if you've learned enough to apply it to midwifery, then the NHS will cover you for that. Obviously, if you do something for which you haven't been protected by that vicarious liability, you risk jeopardising your midwifery as well as your use of the complementary therapy. If you work in private practice, the Royal College of Midwives will only protect you if you are providing occasional treatments. So you would need to have some other insurance to protect you in private practice. And all of our courses are accredited by the Federation of Antenatal Educators, so you can get insurance for private practice. Just looking at the risks of natural remedies. As I started to say earlier, you know, we have got problems in that women think that natural means safe. But if it's got the power to do something, that could be the power to do good, or it might be the power to do harm if it's not used appropriately. Usually the problems occur with women taking too much, or they're taking it when their pregnancy is already compromised. So anybody on any medication needs to be really careful with natural remedies. They actually need to be careful with manual therapies as well, and I'd like to think that they are encouraged to tell their midwife that they're using or they're seeing a therapist for a treatment. But I think it's more so with the natural remedies. This even includes things like herbal teas. You know, we think that they're just something to drink, something nice. But look at chamomile tea. You may know that chamomile tea can help you get to sleep. But if you drink too much of it, it keeps you awake. There are some herbal teas that you probably should not be drinking, certainly in large quantities during pregnancy. But it, you know, very much depends on the individual and their well-being and whether they've got any obstetric or medical implications. This is the other problem. They often don't tell us. And almost all surveys that have been done on the use of complementary therapies, both in pregnancy and non-pregnant patients, shows that people don't tell their doctors or their healthcare professionals that they are using complementary therapies. Now, I think we should be asking women at booking, when we're talking to them about, you know, are you taking any medication? We should be saying, do you use any complementary therapies? Do you ever see a therapist? Do you use oils at home, or do you use homeopathic remedies? And we should be documenting that. I think we need also to ask them again in the 3rd trimester when we're doing the preparation for birth consultation. Are you taking anything, or are you thinking of using anything to help prepare you for the labour? That's when they might talk to you about raspberry leaf tea, for example. And then when we meet them in labour, what have you done so far to help with the pain or the contractions or whatever? And they might say, well, you know, I've had my aromatherapy diffuser on in the bedroom, or I've been drinking some herbal teas, or, you know, I've taken various other things. So it's really important that we know what mums are doing so that we can help them and we can make sure that what they're doing is safe. So as I said, we want midwives to be well trained in complementary therapies for those who wish to do it. I mean, there is the other end of the spectrum, of course, and that is high-risk midwifery. That's not my field, and I would defer to somebody else who knows more about looking after women with high-risk pregnancies. But similarly, complementary therapies is a specialism, and I would actually like to see a midwife in every single trust who is the responsible person for complementary therapies, so that other people can refer to them. Because I think it's very easy to say, oh, I don't know much about that, and then abdicate responsibility to a certain extent. You know, a woman might ask you about something, you say, well, I don't know anything about it. And that's not particularly helpful. The courses that we provide are all academic level 6. We don't want you just to know what you're doing, we want you to understand what you're doing. I mean, you could learn, for example, aromatherapy in a single day and think that that's all you need to know, but you wouldn't expect somebody to come and do a day of midwifery and then start practicing midwifery. So it works both ways, really. We've already said that the Nursing and Midwifery Council code is really important. We have to work within that, and we also have to look at how we use our different therapies within an NHS setting, if that's where we're working. The teachers need to be fully qualified in the therapy. So cascade training is absolutely not appropriate. You need to be able to teach people so you can answer all their questions. You need to have experience of using the therapy within midwifery and consolidating your knowledge, and you need to be qualified and insured to teach as well. This is something of concern to me at the moment, because I think it's very easy to think, oh, I've done that, I know about that, I'm using it in midwifery, and I'll now start teaching other people. But you would normally have somebody who's fully qualified in midwifery to teach you an element of midwifery, and therefore you need somebody who's fully qualified in the specific therapy to teach you about that. So the courses that we offer, we have been running courses for 15 years, and our signature programme, the Diploma in Midwifery Complementary Therapies, has been running for, I think, 12 years now. Within that, it's a 20 study days. It's usually taken over 1 or occasionally 2 academic years, and there are 6 compulsory days, and the rest you choose from a selection. So you can tailor-make the programme to the therapies that you're interested in. We also have half programmes, so our certificate programmes are 10 study days, again quite often spread over an academic year. And we have programmes in acupuncture, aromatherapy, reflex zone therapy, which is a German clinical style of reflexology, and in clinical hypnosis, which is a little more than hypnobirthing. It's actually about hypnotherapy. And then all the short courses that we offer, 1 or 2 or 3 day courses, they can be taken within the other programs. So the short courses are also open to people who just literally want to come and do, you know, a day on moxibustion, for example. But you can put all of that into the program if you so wish. The acupuncture program's now been running for, I think, 6 years, and that's very popular. And obviously there's a mix of theory and practical on all of our courses. And then more recently, about the last 4 years, we've also been running business training for midwives who want to work in private practice offering complementary therapies, or indeed offering other things like antenatal classes privately, or tongue tie division or something like that. And we offer a licensed consultancy scheme, which is a little bit like a franchise, but a bit more flexible. It allows you to set up your business in the way that you want. It enables you to work full-time in your business, or maybe half-time and then the other part of your time in the NHS. And within the consultancy, you have your chosen programme, so diploma or certificate, or you can do 2 certificates if you want, plus full business training and mentoring, support to set up, and then ongoing support with a group of like-minded colleagues. And also we have regular monthly Zoom sessions, which are online, a bit like Skype, to discuss problems that we've come across, both business or clinical. We have an annual networking day for all of our licensed consultants, and various other advantages that you get from the system. And you can talk to any of the team today to if you're interested in that sort of thing. And so that's what we have offered. We've got on offer for you today. We're going to be doing some demonstrations. We're going to be talking about different elements of complementary therapies, and you can obviously have a chat with all of us and get involved and see what you want. I've also put out some books and things there. The latest ones of mine, I do have copies if anybody wants to purchase one, and of course you get it signed by the author. So that's that. Any questions anybody'd like to ask?
I'm going back to the study.
The Kennedy study, yeah.
Why do you think it's more popular in Russia?
I think perhaps the culture is that it's a little more flexible in terms of their healthcare, actually. And because there is not a national health service as such, people are often looking for other ways to deal with minor healthcare issues. And you see this in other countries too, where it's almost a part of the way that people live their lives. Europeans, I think, on the mainland, also will often use a combination. For example, in France, homeopathy is extremely popular. In Italy, the use of herbal medicines and midwives' use of herbal medicines in practice is very dominant in their practice, actually. And then you've got other countries where the system is very medicalised. So in the USA, for example, it is a reasonable number of women are using complementary therapies, but because they're also dictated to by obstetricians, perhaps it's a bit less. And of course you then have to take into account what the study was actually asking. And sometimes these studies are a bit flawed because the way you ask a question might get a different answer. So for example, if you say to women in the UK, are you taking ginger for nausea and vomiting? They might all say yes because they're eating ginger biscuits, but that's not a therapeutic dose of ginger. If you ask women in another country, do they use ginger for sickness, they will generally be drinking ginger tea in a therapeutic dose or taking other ginger products. So it really does depend how you ask the question in a study, a survey type study. Have any of you had episodes where you've had women coming in with their therapies or asking you different elements of complementary therapies? Really? I'm quite surprised actually, because I would have thought that the main London hospitals, because you've got such a wide demographic of women, I would have thought that some women would have brought their oils in, or maybe told you they've been taking herbal remedies or something. Yeah. None of you? Yeah. You have? Okay. And what was that? Was it oils?
It was a combination of things in terms of supplementing with herbs and oils.
Yeah, and was this labour?
It was a little bit antenatal as well.
Yeah.
With labour, I only saw oils being used.
Right, okay. And how did you deal with that? Did you say, oh, I don't know anything about it, or yes, carry on, or no, you can't? What did you actually do about it?
Because of my background as a herbalist,
okay.
I kind of helped them a bit more. I asked questions like, why are you using it?
Yes.
Since when are you using it? What do you want to do from this? But I didn't want to shut them down and say this is not appropriate to use it. So I just kind of left to that they need to make a decision whether they want to use or not.
Yes.
But because I'm still a student, I'm kind of backing up and saying.
And you had the extra knowledge there, so that's really good. It's more difficult if you don't have that knowledge. And I think it is important that we record that we've had those conversations, even if it's a fly-away question about, oh, can I start taking raspberry leaf tea now? You need to discuss with them why they want to take it, when they need to start it, what the appropriate dose would be, and also work out if there's any contraindications. So you wouldn't want a woman using raspberry leaf tea if she's got any medical or particularly obstetric complications, because we know that raspberry leaf has chemicals in it which which tone smooth muscle. So that's going to impact on the uterus, but it's potentially going to impact on the blood vessels and the gut as well. So, it's not quite as simple as just saying, oh yes, take raspberry leaf, even though women have been taking raspberry leaf for decades and decades. It's quite, we need this specific knowledge really, I believe. How about you? If you come across women you're in the same unit, aren't you?
We're at the same university but different.
Okay, so yeah, and what about in your unit? Have you had women?
There were a few midwives that attended the study day, so a policy was put in place that you could only suggest or promote, I think it was aromatherapy, if you'd attended the study day. So we did have one lady who came in with, I think it was lemongrass oil, and there was one of these midwives in attendance on the unit that day, but she hadn't been trained in lemongrass.
No, yes.
It was all a bit unfortunate. She used it in the end, but
yes. Did you not have oils available to replace the? Yeah.
we did.
Because that's the other way of dealing with it.
We did, but she really wanted lemongrass
Yes.
oil,
Yes.
so we let her use it.
Okay, the lemongrass is safe enough for labour. However, it can cause quite a lot of skin irritation, and so I would want to be certain that she didn't have any skin problems. And I think the issue is beyond just the single oil and not knowing about the single oil. The issue is about understanding how it fits within your midwifery accountability. It sounds as if it was dealt with well, in that you were saying to her, look, we don't know about this one and therefore we're not sure if you should use it. But I probably would have discouraged her from using lemongrass in labour if I didn't know anything about it. And the NMC code does actually say that, of course, we want to be women's advocates. We want to encourage them to do what they want to do, but we also have an obligation to make sure that what we're doing is safe. And it could have been another oil which might be contraindicated, both in pregnancy and labour. For example, basil oil or rosemary oil. They're quite popular oils, rosemary in particular, but that is contraindicated in pregnancy and childbirth, and it puts the blood pressure up. So if you allowed her to use it and you didn't know about the effects on the blood pressure, and then her blood pressure started to creep up, you might think that something was going on, but you wouldn't necessarily associate that with the oil that she'd used, because we just think those oils are nice, don't we? Okay, if that's what you want to use, you use it, but that's not necessarily the message we need to be getting across. I'd like to see the message coming across earlier in pregnancy, where we're all able to talk to women. Trouble is, if you ask them a question, you've got to know what you're talking about. and sometimes they'll ask you a question and you think, I don't know about that bit. So we do have a duty to try and find out. But it is so popular now, especially oils, but also some of these other things, that I actually think we've gone past the point at which we should see these as a bit on the side, as it were, a bit of an extra that is nothing to do with us as midwives. It is to do with us as midwives, because they are the women for whom we are caring, and they may be doing something which might affect the progress in the pregnancy or the labour or something like that. Thank you for that.
Where do we stand as midwives if we have a woman in our care that has a doula who provides any complementary therapy like homeopathic drugs or aromatherapy, or if she comes with a kit, because they often come with a kit that was supplied by their aromatherapist and their doula, but they go, oh no, I know how to use it, and often the partner will administer it.
Yes,
so
yes.
What would our kind of responsibilities be then?
Yeah, it's an interesting one, that, because of course many doulas are trained in whatever therapy they're using, and others are partially trained in the way that midwives are partially trained. And of course they are there to be the mother's advocate, almost more than we are in the current climate. But we still have an obligation to the women for what is being offered to them. I would like to have had a conversation with a doula, preferably beforehand, but that's perhaps not likely. Certainly at the beginning of the labour, and, you know, chat with her and see what she can do to enhance the mother's care. Hopefully she might then start talking about, well, I've got these oils, or I might have homeopathic remedies or something like that. But your duty is to write down in the notes whenever those therapies are being given. So I would like to see a record of aromatherapy commenced or homeopathic remedy given, even if you know nothing about it. At least then you get a means of correlating whether the administration of a particular type of remedy had any effect on the fetal heart or the contractions or something like that. If somebody's got a CTG going, then I'd like to see it written on the paper of the trace. Aromatherapy commenced, aromatherapy discontinued. And of course you also have a duty to say to the women, you know, this is something that is not part of my remit, unless it is, of course, but it's also we may need to advise you at some point, if anything starts to go wrong, might need to advise you to discontinue that remedy. You know, you are taking it on the responsibility of the doula and yourself, and you're very welcome to use it at the moment. But if anything does start, you know, if we do start developing any variations from the norm, then it may be appropriate to discontinue that. And it's a difficult one because they're usually really keen to use them, and the doulas are really keen to use the therapy that they're offering. But
we don't have to write what they're using, we can just write the
You might not know what they're using.
Yes.
One thing I would say to you though is, if the woman is taking any homeopathic remedies, she can't use aromatherapy at the same time, because homeopathy doesn't work like drugs. It's very chemically fragile, and it does mean that the strong aromas of the oils can inactivate the homeopathic remedies. So it won't necessarily do any harm, but it's a bit of a waste because you know, it's just inactivated. But it may be that a remedy is given that you don't know, and therefore all you can do is, you know, doula has given a remedy, or doula has started the use of aromatherapy, and that applies whether it is a qualified practitioner, or even if the partner wants to start using aromatherapy, you know, why they're doing it and what they're doing, and just make a note of it really. Yeah.